Hello and welcome to Aspen and Arbor's documentation standards. We'll be talking about evaluations, research, and discharge summaries because these documents need to reflect the best of our clinical judgment and show the individualized care that I know we are providing. So the quality matters, it counts. It counts in so many ways, including hopefully getting a little bit more time from our managed care companies. If we have solid, objective, evidence-based evaluative findings and updates, we are more likely to get a little bit more time from those managed care companies to continue treating the people that we want to progress to a higher level. It matters in terms of our licensure protection. We want to make sure that what we document is in line with the licensure laws, that we are abiding by the standards of practice per our state guidelines, and that gets reflected in the quality of the information that we share, the entries that we create. We want to make sure that we're documenting adherence to our professional standards. So APTA, AOTA, ASHA all have ethics and integrity standards, and we need to make sure our documentation reflects compliance with those as well. The documentation that we create needs to record the sophistication of the care that we're providing. So we know that we have college degrees. We know we have a lot of information and education under our belts to help get people to that better level of functioning. Our information that we share through our EMRs, through our documentation, needs to show our smarts. It needs to show what we went to college for and show that we are actually using good clinical judgment to help progress a person from one level to the next, what we need to break down, what interventions might be effective for that person, and guide that person's rehabilitative process. So we need to show that we are providing the skilled therapy that nobody else could do. When we do that, we're also going to be reducing our risk for denials. Just like we appreciate getting a paycheck, our facilities, our customers, and our employers also appreciate getting paid ultimately from CMS for the quality of the documentation that we provide and the interventions that we're performing. This is also going to help us if we have solid documentation from a liability standpoint. You know, the cliche, if it's not documented, it didn't happen. We definitely want to make sure that we document adherence to things like precautions or contraindications, the safety measures that we've put in place for a particular individual. Make sure you're documenting that stuff to protect your license and protect, obviously, the resident, the employer, the customer. And then finally, we want to have good team communication. So if we have solid, good documentation, we have better information being exchanged interdisciplinary wise, as well as from the assistant to the clinician, clinician to the assistant. We want to have really good, clear communication lines. And again, good documentation can support all of that. When we start with the evaluation, the top part of it is looking at the ICD-10 coding. And we know that we need to choose the primary diagnosis per nursing, what they say the primary diagnosis is going to be. But we might also need to add one or two more additional codes to support that plan of care. So for OTs and PTs, any kind of other neuro or ortho diagnosis that might be impacting their current functional picture, you might want to pop that into that top ICD-10 code listing, because that'll help jump out at a reviewer. This isn't just a typical person with pneumonia, for example, but they also have a recent history of something orthopedic or something neurological going on. The same for speech therapy. I think it's particularly important if somebody from speech therapy is going to be picked up seeing a client for somebody who's had a hip fracture, for example. That doesn't necessarily mean that they need speech therapy. But when you add in the fact that they have dementia or Parkinson's or any of those things, that helps fortify your plan of care. So we do need to add in perhaps one or two more additional diagnoses at times to support that POC. Include any kind of recent diagnoses that are going to impact the rehab picture as part of that reason for referral. So you want to note the comorbidities on their current functional status and make sure that you've included that information so that we have that solid clinical picture being created. That reason for referral needs to show why they need therapy now, what's changed, what's happening. So we need to relate any kind of functional changes to medical diagnosis when we can. So for example, if we've had a decreased ability to swallow due to exacerbation of dementia, we're linking dementia to swallowing. Or we might link, late effect of failed hip fracture repair to decreased ability to transfer. So we can link those things and make that a much more solid claim, I guess I'll say. Self-referral needs justification. So those that would come down to therapy saying, hey, I'd love to be able to toilet myself or walk and live or eat a regular diet, of course they would. But that alone doesn't justify why we're doing the evaluation. In that reason for referral, we need to defend and document why we feel it's appropriate to at least do the evaluation. What are we looking at as a possible indicator for them having that potential to improve in that area? So family referrals, self-referrals, we need to weigh in on our clinical judgment and explain why we feel that it's appropriate to do that assessment at this point in time. When we're looking at prior level of function, we want to document their recent best ability to function, which cannot be not applicable or did not test, especially if we're writing a goal for that area, because CMS is going to come back and say, you don't know that they're not already at that level, at that status. So we need to have clear information about that prior level. I know clear information can be pretty tricky to find or get sometimes. Might be on the chart, it might be in the EMR, it might be with whatever documentation comes over with a new admission. Sometimes we don't have that, and the best we can do is say it's per patient report or based on prior living environment. And that at least kind of qualifies that we may question the accuracy of this information, but we are basing it based on the fact that they supposedly lived alone or that the person told us they were doing certain things. That kind of gets us some qualifications that we know it might be questionable. Our prior level of function, the information needs to support our goal levels that we want to establish, or we need to justify why we're going to be going above that prior level of function. So CMS pretty much says you can't get people better than their recent best ability to function. That's their stance. However, we know that that's not always true because sometimes people have new medications, new equipment. There's been a change in their weight-bearing status, their alertness, their wound might have healed. We need to carefully document that information to show why it is now appropriate to go above that recent prior level of function. And remember that prior level of function is not the status upon their recent discharge back to the hospital. So if they came to us, they were at whatever level when they went back out to the hospital, they come back to us, we want to choose that initial prior level of function because that's going to best support where we feel those plan of care goals, what would be achievable, what would be realistic with those plan of care goals. Okay, so again, reflect back to their recent best ability of function. There may not always be a time frame with that. With the baselines, again, another important aspect of our documentation needs to have valid, solid baselines. Every goal needs to have a baseline, and it needs to be documented in the body of the assessment, not just in the plan of care, but also as part of your evaluative findings. So if you're going to have a custom goal, this is sometimes where I see it's a little bit of an issue. You might have a custom goal for a person to remember 4 out of 5 safe transfer techniques. That is nowhere cued within Net Health. So you're going to have to grab that little piece of paper off to the right-hand side, wherever it's appropriate, to say that they currently recall 0 out of 5 transfer techniques, or whatever it might be. So make sure you validate your baseline within the body of the eval. It'll show up again in the plan of care. You can't have a baseline of did not test or not applicable because, again, CMS is going to say, how do you know that they're not already at that status? So you need to have a valid baseline. I know that there's times when a person's going to refuse to get out of bed or decline doing a particular task with you, whether it's from pain or fear, fatigue, whatever it might be. So in those situations, you might have to document unable or dependent when you can't hands-on assess that particular skill. In that situation, you can go from dependent or unable to min assist or whatever the appropriate level is. CMS does understand that, but they don't understand a not tested to a higher level of function. That makes no sense. Speaking of logic, you want to make sure that your documentation is logical. So for the OTs and PTs, if their range of motion is within 75% of functional limits, that's not full range of motion. So their manual muscle test should not be 3 out of 5 unless you quantify that 3 out of 5 is within available range of motion. Okay, just like you're probably not going to have somebody with poor dynamic standing balance be standby assist for a functional transfer. So make sure your information is logical. And I can't overstress the importance of doing standardized testing. It's so helpful to have that baseline of standardized, objective, evidence-based information to support our findings as we progress through the rehab process. So a quick minute on section GG. I know there's been a lot of training on this. Remember to score all GG areas per your discipline upon admission and upon a planned discharge if these things are occurring within 3 days of your visit, okay? Use the Net Health subcategories to support your GG scoring. So again, in Net Health, you can break out, for example, bed mobility is also broken out into rolling, supine to sit to supine. Document those areas. It's 3 quick clicks, and that way you've got supportive information for your GG coding and scoring. Because we know sometimes there might be one level for rolling, but a different level for supine to sit. Same with footwear for the OTs. Lower body dressing and footwear can be 2 different scores. So break out those areas and make sure that you've got that supportive documentation for your GG scoring. Double check and document why some things may not be apparently illogical. So for example, if somebody is scored as a 0.9, meaning not applicable for bed mobility, That's a little bit unusual because most people do have a prior level or prior need for performing bed mobility. But you might then need to explain that they slept in a recliner, high level quadriplegia, they are unable to do bed mobility. You might need to explain or double check for errors if you've scored, for example, transfers are coded as a 2, meaning max assist, but they can walk 10 feet, scoring them as a 4, meaning they walk 10 feet with standby assist. Again, that doesn't make sense. So make sure you double check for accuracy and for logic. And consider writing plan of care goals for areas such as uneven surfaces, curbs or one steps, car transfers, item pickup. You can include that in your existing goals. You might have a goal for the person to perform all functional transfers with min assist, including car transfers, or perform community mobility with contact guard assist, including uneven surfaces and curbs. Perform homemaking skills, including item retrieval from floor, with contact guard, whatever it might be. But that will cue the assistants to make sure they address those areas, and that'll make it much easier for you when you're going to do your discharge GG scoring, that you have that information available that's been addressed and it doesn't somehow get overlooked. For the speech therapist among us, so we want to make sure we're looking at how we can support our PDPM scoring and coding, and that typically happens through Section C and Section K. Section C basically is the BIMS, and we need to make sure we have that information to support their cognitive status. So when you're doing your assessment, I know the BIMS is a screening tool, but quickly you can document information about their BIMS because you are looking at orientation typically as a part of your cognitive assessment. You might need to provide some additional cognitive tests to support cognitive deficits, especially if their BIMS score is 13 or higher, which in CMS land means they have no cognitive deficits. We know in reality that's not a very reliable indicator of their cognitive status. So you would want to do additional testing like a SLUMS, a MOCA, GDS, the ACE, whatever it might be, to have that evidence-based objective information to verify, yes, they do in fact have a cognitive deficit, even if they aren't oriented. Again, you need to do Section C and Section K worksheets. If you have questions about that, please talk to your FRC. That information is also housed in our employee portal. Accuracy is going to be particularly critical at this time, and this is true for all disciplines. Because PDPM has cost CMS more money than they're anticipating, they're really looking to see if we're coming up with accurate scoring for the case mix indexes. That case mix index is based on our Section GG information, our Section C and K information. So as therapists, we've got to be sure that we're providing good, solid, reliable information to the MDS nurse so that she can score it as best as possible, as most accurately as possible. And I think when I look at speech therapy scoring things like cognition, I believe that speech therapists are the experts at standardized cognitive testing, along with some OTs also that have made that their passion. But we as therapists do a lot more standardized testing than nursing or social work ever does. And we know how important it is to stick with the script, not overcue, make sure that we're very careful about that scoring criteria so that we are giving good, reliable scoring information to that Section C information, for example. So social work and nursing commonly are cited as overcuing, not following the criteria very carefully. We know how important that is. We're probably a really good resource for that MDS nurse with Section C information. When we're looking at goals, we want to make sure that our goals are going to be measurable and functional. We need to make sure that we have goals for pain, range of motion, and so forth to have that functional component. So for example, we might have a goal for that person to have no more than 3 out of 10 pain in the left shoulder to enable upper body dressing. Okay, we need to have at least one measurable and functional short-term and long-term goal in net health, and those should not be the same goal. So it can be helpful to perhaps have a long-term goal. If we just have a real small plan of care, like we want to tweak something on a wheelchair, adjust a splint, do a double check on diet, consistency, safety, we might have a long-term goal for a caregiver training, and then the short-term goal would be patient-driven. So we could have a goal, for example, for the caregivers to demonstrate good competence with a particular area, or the caregiver would be 100% accurate with safe swallow strategies. But remember that having goals to assess an area or to test an area, those are not measurable and functional for that person. So I sometimes will see a goal to be assessed for a custom wheelchair. That's something we're going to do. That's not measurable and functional for that patient. So testing and measuring kind of goals are not necessarily, testing and assessment goals are not necessarily patient driven. We need to avoid putting those goals on our plan of care. It is, however, okay to put a standardized test goal on that plan of care. So if you want a goal for that person to score at least 25 out of 28 on the Tinetti to enable safe ad lib mobility in the facility, that's fine. That's a good solid goal. but not just to assess for, wheelchair needs or that type of thing, okay? Talking about evaluation codes for the OTs and PTs that are listening, information about the accurate use of OT and PT eval codes are on our website under the employee portal. Plus, we know that certainly on our professional websites for AOTA, APTA, they've got a lot of information about the evaluation codes. Remember, though, that a person needs to qualify for the complexity rating in all of the areas, or they're going to code out at the next lower category. So, for example, if somebody codes out as a high complexity and a high complexity in 2 areas, but that third area they code out as a moderate complexity, then their evaluation code would be for that moderate complexity. Okay, so 2 areas are highly complex, 1 area is moderate, they're going to code out as moderate complexity. For group therapy, remember that CPT code for OT and PT is 97150. For speech therapists, that CPT code is 92508. For speech therapy, remember that you can only be providing cognitive communication groups. Dysphagia groups are not allowed per CMS. Per CMS, we do need to justify the use of group interventions in the plan of care, and this may be a slightly new wrinkle for some of us. So we want to make sure that in the plan of care, in the body of the evaluation, we're justifying why we feel that groups might be appropriate for that individual. So I recommend that you put that information in the clinical impression build box. You will be already filling out that information. You may add free typed information to clinical impression, and you will need to free type in a phrase that would justify why a group intervention might be appropriate for that person. So here's some sample phrases like group therapy might be indicated to promote function in a more distracting community-like environment. It might be indicated to promote peer-to-peer education, or it might be indicated to promote autonomy and self-initiation, or it's appropriate for peer-to-peer motivation. There's a host of other possible phrases that you might want to use. That information is found in the group therapy binder, the introductory page that is also housed on the employee website portal. You can look that information up and get more ideas, plus certainly your own information as well. But we do need to justify groups. Some other final important details for evaluations: to remember to click on the build box beside the clinical impressions in the clinical impression portion, and then click on continue to complete justifying the frequency and duration for that individual. Make sure that you always write a treatment encounter note that supports any kind of treatment codes that you might be billing on the day you're doing an eval, Recert, discharge, progress note. Don't just document C-eval. If you're billing for a treatment code, make sure you document what treatment you've provided. And you can certainly use those 10 phrases, the build phrases, to build that 10. So just a brief screenshot from NetHealth. When you, under the clinical impressions portion, there's that TXT box. You click on TXT, it will bring up some of those pre-queued phrases. Click on up to 3 of those, click on continue, and that'll support our frequency and duration. This is the spot where you'd also would want to add in your justification for groups for our Part A folks. Again, we're probably not going to be doing groups with our Part B individuals because CMS feels that our long-term care residents, typically our Part B folks, benefit most from one-on-one interventions. The same would be true for our Managed B individuals as well. So we want to make sure we justify groups for our Part As. Moving on to progress notes, make sure that you review the notes and you talk with the assistant so that you get any kind of updated status on what's going on for that individual. So we're giving good information in that progress report. Update the goals, either downgrade or upgrade or downgrade as necessary, depending if they're making gains or not. Again, you need to make sure that we're justifying why therapy should continue. So if they're not doing well with, for example, the stand pivot transfer, you might have to break that goal down into just standing balance and sit to stand skills. Again, depending on, we want to be able to show gains. So if they're not making gains, we need to break it down potentially. And you want to document patient-specific skilled interventions in that skilled portion of the progress note. Make sure you can use some of the build phrases, but also free type in some individualized specific information so that that individualized note is evident from person to person, as well as in that one person's episode of care. You don't want each progress note to look the same. Keep it individualized. And also, this is a good chance to explain any reason for a delayed in progress and why we think therapy should continue. So if they've had a temporary setback from a UTI, expected gains, expected to continue making gains, just clearly document that. Also for OTs and PTs, you want to use a supervision phrase that's going to indicate communication or consultation with the assistant. Again, those are any one of the last of the 5 options in that build box. Again, we always have access to each other anymore through paper notes, through cell phones, that type of thing. So make sure that we document that we've had communication or consultation. Again, I want to repeat that standardized testing to objectively show the gains that they're making, where they're at, So important to quantify and verify the gains. So if you've done it in the eval, great time to review it on the progress note or on a Recert. So talking about Recerts, again, the data needs to justify continued therapy. We need to explain any delays in progress or decrease in goal-related status, as we noted with the progress note. We want to update the goals as necessary so we can advance them as appropriate. And we need to definitely show the progression of care. When you're documenting that Recert, there's the portion where it's looking at the summary since the last progress note, which should not be the same information as the summary since the eval. So technically, day 30 or day 60 of therapy shouldn't be the same interventions as what we were doing on day 1. We need to show that progressive, dynamic, skilled interventions that we're doing. So we might help to start that phrase that, since the last progress note, treatment has focused on, maybe we were initially starting out with sitting balance, now we progressed to standing balance. We did some pre-feeding skills, now we're working on actual oral intake. Those kinds of things would be real important to note how we're progressing that person, especially in the Recert, and showing the progression of caregiver training. Chances are we're doing something different with those STNAs as well. Make sure we document that and their response to that training. Within the recertifications, again, be careful to keep the baseline, prior level, and current status clear in your mind. I do read research sometimes where I think statuses got flipped based on the information I see in the treatment encounter notes. The other thing that can be tricky is sometimes with percentages. So I'll see a goal for somebody to be 0% risk of fall, 0% risk of aspiration. Their baseline might be 50%. In the recertification, I see they're at 90%. And I'm not so sure that we've really made them worse, but that 90% would indicate a decline from 50% if you're aiming towards 0% risk of something. So keep the percentages clear. It can be a little bit tricky in that regard. When you write comments under the goal status update, that can be very helpful to explain their status, any delays in progress, the skilled interventions that we're doing, again, standardized tests. With our discharge summaries, again, those need to be done by clinicians, and that is per licensure guidelines as well as CMS regulations. It's our last chance to defend that episode of care. It can justify that length of stay and incorporate our clinical judgment for why we kept them on so long if they've been slow to progress or not making huge changes. It can clarify the status, again, with some of those comments and local updates. Again, we've all seen those people that come in generally at a mod assist level, they progress to a min assist level, something happens to they decline to max assist, we're discharging them at a mod assist level. So it would look like they made really no change. They started mod, they ended at mod, but you need to explain those fluctuations and advances and setbacks along the way to justify that episode of care. So in our discharge summaries, we want to make sure that we note all of the training that's occurred and the results of that training. Real important in the discharge summary to note that did they understand? Did they have good carryover of the techniques and strategies that we educated caregivers or patients on? Again, from a liability standpoint, it's real important to say that, yes, we had good understanding. Otherwise, anything can happen. We want to be very specific and specify the recommended discharge equipment and services, such as the home care, the type of restorative nursing program. Be specific with your recommendations and make sure that we provide accurate data so that we have good functional status reporting for all of the known areas to support accurate GG scoring so we can have those strong outcomes. The GG information, if you're not aware, GG information does ultimately end up on the Nursing Home Compare website. Not as direct as what we see when we're looking at GG, but it does get incorporated into the benchmarks that they're looking at. So if we want our facilities to look good on the Nursing Home Compare website, which is a publicly viewed area, we want to help our facilities earn those 4- and 5-star ratings so that we have managed care contracts. We have to have good GG accurate information upon discharge as well. So we have those good outcomes. Some additional quick considerations: don't share your password. That bears repeating. Don't share your password. Students may only create entries in the sandbox, that clinical documentation box. That's not a real facility. Again, that is a CMS regulation. So we need to abide by that. And do not have an assistant start or open a document for you, because otherwise it could look like they own the document. You need to be the sole owner of a Recert, a discharge summary, a progress note. So do not have an assistant open those documents for you. Their name can get tagged with that. And again, that could be a licensure compliance issue. So you open the documents you need to complete, okay? All right, so as a quick wrap up, point of service documentation can help save us time at the end of the day. We know it's a lot more accurate to do things as they occur. It also helps us to help the resident be more aware of their status. It's a great opportunity to say, hey, what did we do today in therapy? Why did I have you playing catch, for example? What do they understand of that? And can we link it to why it's important for them to participate in the activities that we're providing for them? It can help us help them understand the skilled nature of the tasks that we're providing. We might be able to say, hey, yesterday you stood for a minute, today you stood for 3 minutes. We're making gains, and give them that feedback, give them that chance for that feedback. And we also have a chance to get their input. What did they like about therapy today? What kinds of things are engaging to them? What kinds of things are boring? What's their input towards their goals and their discharge planning? We can have that conversation while we're doing point of care documentation to an extent, and I do recognize that that does not work across the board. But we need to have careful, accurate entries, and that is going to protect everyone. So take your time with it. And again, if you have questions about the documentation, certainly you can contact your FRC, area manager, regional director, or your director of clinical compliance. I want to thank you very much for your time and attention. Thank you for the good work you do.